2049. The aim of the association is to build the foundation strong and to provide knowledge by conducting various seminars.
One of the oldest state chapter in this prestigious association is the Tamil Nadu and Pondicherry chapter. This Tnpciapm started in February 1975-76 in the Pathology Lecture Hall of Madras Medical College by Dr. Sarasabharati ma'am and Dr. Jnana Desikan sir. We are now 46 years young and marching towards a golden jubilee year. The chapter has had many stalwarts and doyens who have made a significant contribution to the fields of pathology and microbiology both at the national and international arena. A short AV.
I will go.
The association conducts scientific sessions and slide seminars every month and an annual conference called TAPCON in the month of July. This year, we, the Department of Pathology, TIRUNELVELI Medical College, are proud to host TAPCON-2022. Great things are done by a series of small things brought together.
TAPCON is held with an objective of providing a platform for exchange of ideas and to have constructive discussions for sharing of valuable experiences in all domains of pathology. The last decade has witnessed explosive expansion in knowledge, research, and therapeutic avenues in pathology. Increasing awareness and rising expectations has widened the knowledge among the postgraduate students and consultants. To achieve this, there is a need to have periodic workshops and academic programs.
Hence, this TAPCON-22 comprises of pre-conference workshops, quizzes, scientific sessions, and slide seminars on various areas of pathology by the eminent speakers, followed by paper and poster presentations by the budding pathologists. In between the sessions, we would like to display the papers and posters we have received as flashcards and would also like to enchant you with delightful pathology quizzes and snippets. Along with this academic feast in Tirunelveli, we also like to cater a dinner fest and an enchanting surgeon to spa of South Tamil Nadu.
A good start is half done. The previous day workshops on liquid biopsy, karyotyping, and experimental studies on zebrafish was a great success, with enthusiastic participation from postgraduates of various colleges. This was followed by a mind-boggling quiz conducted by the faculties of Chengalpattu Medical College. A short glimpse of yesterday's academic events conducted at TAPCON-2022.
An investment in knowledge pays the best interest. Only source of knowledge is experience. Reading maketh a full man, conference a ready man, and writing an exact man.
We shall now move on to the scientific session of day 1 of this conference.
Cancer has enormous diversity and behaves differently. It's highly mutable, the evolutionary principles are very complicated, and often its capacity to be constantly mystifying comes as a big challenge, is a famous quote from the Pulitzer Award-winning book, The Emperor of All Maladies by Dr. Siddharth Mukherjee. Perhaps cancer of no other side is more mystifying or challenging to pathologists than that of soft tissues. Over the last 10 decades, the pathologists are trying to demystify the extensive and evolving spectrum of soft tissue tumors. Let's have an insight on recent advances in soft tissue tumors, newer diagnostic entities, immunohistochemical markers in intertumor relationships by Dr. Bharat Rekhi sir, Professor, Department of Pathology, Tata Memorial Center, Mumbai. We welcome you, sir, to the dais.
Chair the session, we invite Dr. S.S. Sundaram sir, Professor and Head of Department, Surgical Oncology, TIRUNELVELI Medical College. Sir did his undergraduation and post-graduation in Madurai Medical College and MCH in Keelpark Medical College. Sir has worked as a Senior Assistant Professor in Regional Cancer Center, Kanchipuram, till 2011 and Associate Professor and Head of Department in Government Rajaji Hospital, Madurai, till 2015. His service in the Department of Surgical Oncology, TIRUNELVELI Medical College since 2015 is highly laudable. It's an immense pleasure to have you here, sir. We would also like to invite Professor Dr. A.V. Shanti ma'am, former Director and Head, Institute of Pathology, Madras Medical College. Ma'am has served as Faculty of Pathology for more than 30 years. She is retired in June 2008 as Director and Head of the Institute of Pathology, MMC. She initiated a postdoctoral fellowship course in cytopathology, affiliated to the TN Dr. MGR Medical University. Madam has received the Best Teacher Award and has the prestigious opportunity to work at Armed Force Institution in Pathology, Washington, D.C. And she is a recipient of B.C. Roy Scholarship for postgraduates. She delivered the TN oration at the National IAPM conference held in Chandigarh in 2019 and has presented many papers and posters at the national and international conferences. Her enthusiastic leadership qualities has been a constant support in the field of pathology. We welcome you, ma'am. Now we request the chairperson, Dr. Sundaram sir, to introduce the guest speaker.
A very good morning to all of you. At the outset, let me thank the Department of Pathology, TIRUNELVELI Medical College, for allowing me to be a part of this wonderful TAPCON-2022. As you rightly pointed out, after 2 years lull, we are into physical mode of conferences and CMEs. Pathology has always been a very interesting subject. During my UG days, I was always amused by the pathologists' proclivity to describe lesions in terms of food items, like anchovy sauce pus, fried egg appearance, like that. So I was always interested to go through the books. Even without teaching, I used to read pathology books, like I used to read story books. So I was so fascinated by the descriptions. And naturally, being a surgical oncologist now, previously I was interested initially in anatomy, then pathology, and then surgery. So that those three are, I think, the real backbone of any surgical specialty. Today, I have the opportunity to introduce you to the eminent speaker, Dr. Bharat Rekhi. He is the professor and pathologist G at the Department of Surgical Pathology in Tata Memorial Cancer Center, Tata Memorial Center, Mumbai. So his areas of interest is oncopathology. So naturally, I am very eager to listen to what he has to say today, especially the soft tissue and bone tumors. And his areas of research are clinico-pathological studies in novel immunohistochemical and molecular markers. He has 21 years post-MD experience. That is really a vast experience, and that too in eminent institutions like Tata Memorial Center. So he has various achievements to his credit. He has won the grand prize for the best electronic poster exhibit at the International Skeletal Society in Rome, Italy, and he was awarded Srimati Kunti Meghrotra Best Published Paper in IAPM 2012 and Dr. V.R. Kanolkar Award for Best Published Paper, IAPM 2018. And he was in the editorial board of IARC, IAC, WHO reporting systems on cytopathology, first edition. And he has various publications to his credit, about 256 in number. I'll just say one or two. He was a responsible author of 2 chapters in the 5th edition of WHO fascicle of soft tissue and bone tumors. He has contributed 3 chapters to Encyclopedia on Pathology. So he has various publications to presentations made. He has an invited member and speaker at the Rare Cancers Group Asia, ESMO Asia 2019 at Singapore, and he has also chaired session and moderated in International Academy of Pathology at Glasgow as well as in Gothenburg, Sweden. So he has held various positions in the journals. He was editor-in-chief of the Indian Journal of Pathology and Microbiology 2021. He was associate editor in the same since 2019. And there are so many journals, right? He has a vast teaching experience. He is recognized as Homi Bhabha National Institute teacher guide for 9 MD students and observers from Nepal. So he has various memberships to his credit. He is a member of International Academy of Cytology, IAPM, Indian Academy of Cytologists, International Bone and Soft Tissue Pathology. He is training as visiting professor and observership in Mayo Clinic, Rochester, USA, and various other places in UK and USA. So I request Professor Shanti say a few words.
Good morning, everybody. I thought I will give the concluding remarks after listening to a fabulous talk. Okay. Can I say a few words, Swaminathan? Yeah. At the outset, I'd like to congratulate Professor Swaminathan and his team for this wonderful, excellent organization that he has made. And I'm really touched beyond words because during the pandemic, where did we think that we could all meet once again? And to have a conference of this stature in Tamil Nadu, the IAPM chapter, I think we are indeed blessed. and heavens have blessed this team immensely. So I don't want to take up much of your time, but just one word, because I'm a Rip Van Winkle, I should honestly say, and a former director, and been very passionate about pathology in short, especially cancer pathology. And I think today's students, the young postgraduates, are all of a different era totally, and they are exposed to a lot of technology, computer work, which we didn't have during our time. So there's a lot for them to imbibe and learn and to go about. But my only request is never forget your fundamentals, and that's what we have been taught. And lastly, all of us would have lost some near and dear ones, our own colleagues, very excellent teachers in medicine and doctors during the pandemic. And at this moment, I would like to remember my teacher, UG and PG, Professor Tilagavadi, which many of them would know. She was an excellent pathologist in South India, par excellence, I would say. And we do miss many of them like that. I think this session, I would like to dedicate it to her, because she was such a kind, a clinician-friendly pathologist. That's what a pathologist needs to be. With a neuro person sitting beside me, I know how important it is to relate to their needs and criteria. Then just a concluding remark. When I see some saris here, which are all that ikat and pochampalli type of pattern, I'm really reminded how a pathologist's mind works towards patterns and diagnosis and uses a special stain, etc. That is another thing which brings out the liveliness of the session. Over to you, Dr. Bharat Rekhi. Thank you so much.
Sir Swaminathan, for this prestigious TAPCON, the Tamil Nadu Pondicherry's chapter of IAPM. I really congratulate you, sir, for having this conference CME in real, and this is my, I think, second real meeting. I think the previous one I came quite a few months back for the cytology meeting and had great fondant memories. That was kind of propelling me towards to accept your invitation. I'm very, very happy and very pleased and delighted to be here. Thank you, chairpersons, for a very kind introduction. And I completely echo, ma'am, your feelings that what makes us presently the most important part of a clinical team is how we learn from our fellow clinicians, and that's always a mutual exchange of knowledge, all catering towards patient care. That's the essence of a pathologist. And with these few words, I'd like to begin my talk related to the approach to diagnosis of soft tissue tumors. My view is what I have understood and learned, and it's always a journey that we keep going through, and we never stop learning for the postgraduates here. So the plan of my talk quickly is going to be, we look at the background of the soft tissue tumors related to their incidence and how we approach towards the diagnosis. Trying to answer three to four clinically relevant questions, which is important. We look at the importance of our good friend, Okay. Look at the role of our good friend immunohistochemistry, how it helps us in a more precise diagnosis towards not only diagnosing, also prognostication, and to an extent even theranostic value. Then we look at some case scenarios looking at the importance of how the NCD techniques help us. Yeah, it's okay. And then finally, I'll wrap my talk with some takeaways. So looking at the background, soft tissue tumors are common, but sarcomas are rare. They form about 1% of the total cancer burden. Considering I come from a referral cancer center, these form about 2.2% to 3% at our center, with males clearly outnumbering females in the most tumors that we see. Even though sarcomas are rare, they are complex, they require expertise because they are diagnostically challenging, especially with limited biopsies. And we're living in a world of shrinking biopsies where less is more, and we have to offer more clinical information with a limited amount of tissue. And when I say complex, requiring expertise, that is as a result of a significant clinical, radiological, histopathological, immunohistochemical, and even molecular overlap in the various tumor entities. That are more than 200 tumors, and now there are more than actually 800 sarcomas described in the recent fascicle. So that makes sense because we have certain therapies lined up for specific sarcomas, for example, pediatric tumors. You have Ewing sarcoma with a specific chemotherapy, and this is a chemosensitive tumor, in contrast to a rhabdomyosarcoma that is treated on a different chemotherapy regime. And we're living in a world of evidence-based precision medicine, and we've always been practicing as pathologists precision medicine in a way, trying to give a very specific and correct diagnosis. And when I say chemotherapies, these are expensive and toxic as compared to the cost of a molecular test, which can be helpful in certain round cell tumors for a very accurate diagnosis. So whenever I'm asked about how much is the cost of an EWSR, I say it's non-toxic, and it's certainly less than the chemotherapy that you're going to offer. So that's how we trade off, and we're trying to make decisions towards molecular testing. So we need to tailor these therapies towards the exact diagnosis, and that is the essence of practicing pathology in present times. Try and look at the clinically relevant questions. The pathologist or the soft tissue pathologist has to answer whether it's a benign or a pseudosarcoma, like a nodular fasciitis, which kind of gets missed at many times, or it's a malignant or sarcoma. Something in the middle is intermediate. We don't use the word borderline. Then once it's been diagnosed as a sarcoma, the surgeon would like to know whether he has cleared it completely. And therein where lies our importance to furnish the margins, and I'll come to that in the details. Then whether there has to be an adjuvant treatment to be offered, for example, adjuvant radiation therapy for a better local regional clearance, or maybe chemotherapy in certain spread tumors which are perhaps chemosensitive. And now we have certain targeted therapies also. The best example is GIST in abdomen. And now we have DFSP and other tumors also with their specific targeted therapies. And finally, how will the tumor behave in terms of trying to address parameters that tell about the prognosis of that particular sarcoma or tumor. So that's the best approach of overcoming challenges in management of sarcoma is to practice the triangular approach, and that's very safe. We learn from each other when we work together in the multidisciplinary form. That's the integrating clinical, radiological, pathological assessment. And then we abreast ourselves with the recent advances in pathological evaluation, be it newer entities, newer markers, molecular markers. Actually, more than 1/3 of the sarcomas have their specific molecular markers, so that helps us in a more precise diagnosis. And then that translates further into improved surgery and management, because we are living in a world of salvage. We don't practice more of the radical resection that used to happen earlier. And now we have to look at balancing the functional and clinical outcomes in patients of sarcomas. So that is wherein lies an importance to see how these tumors or sarcomas have been adequately cleared. And that's what one can have it in their mind for the postgraduates, looking at a soft tissue mass to evaluate whether it's a tumor or a reactive lesion, which at community hospitals, the pathologists will be seeing more often than we see, because the range of these lesions can masquerade a tumor, for example, cysticerca cellulosa, hematomas, scars, and parasites that I just alluded to. And once you have made up your mind that it's a tumor, you have to stratify whether it's benign or malignant. Then we have pseudosarcomas like nodular fasciitis, myositis ossificans, ischemic fasciitis, and things like that. Something in the middle is intermediate lesion. We don't use the word borderline. When I say intermediate, you have examples like a locally aggressive fibromatosis, or rarely metastatic, that is the inflammatory myofibroblastic tumor. Because these lesions can recur, but they rarely metastasize, and that's why we don't stratify them easily to sarcomas. Now, looking at the diagnostic modalities, what comes very crucial is MRI for soft tissue mass in the extremities, in contrast to CT for abdominal biopsies. And in bone tumors, we always know how much valuable a plain radiograph or an X-ray is. Looking at the type of specimens, we actually have the core needle biopsy in most cases, and we restrict the excisions to lesions up to 2 centimeters in size. The other excisional or the open biopsies are generally not recommended, even though they are the gold standard, for fear of any spread or contamination of the area that the surgeon has to finally excise. And that's been helpful if you have the core needle biopsy, because it helps in subtyping and grading in nearly 80% cases. That's the Royal Marsden experience, and also we've seen similar experience. Now, final aspiration cytology has its own merits and limitations. It's mostly for recurrent or metastatic lesions, and we need to recognize its limitation. We're trying to make a primary diagnosis, so it should be done only if you are seeing a lot of cases, you have ancillary techniques towards yourself on the cytology specimens. Otherwise, just for example, a diagnosis of round cell tumor in present times is not going to be enough. So we have to utilize ancillary techniques, be it on your cytology material from cell blocks, or ideally it is the core needle biopsies. Now looking at the role of imaging, it tells us about a very crucial parameter, size, extent, and location, because we know large-sized, deep-seated tumors have more chances to be malignant, and in fact high-grade sarcomas, with always exceptions. It also helps us to know the spatial location with the adjoining structures and deciding upon the treatment plan, and for long-term monitoring by our clinical colleagues, that's the surgeons. It helps in yielding a more representative diagnostic material if you combine PET, because you can see the most important area, excluding the necrotic area, which can also be avid. So that helps in yielding a more representative material. And of course, we have certain images which kind of give us an idea whether it's T1 and T2 bright could be a fat-based tumor in abdomen. And if you see a low T2, that could be more fibrous tumor like fibromatosis. That's generally mostly heterogeneous on the imaging. So you can have an idea, and that's what you see in this particular example of this young patient where this almost filling the entire arm, and this little ulceration of this slowly growing tumor. I call it like silent elephant over a period of time. And you see how the contrast imaging nicely highlights this entire tumor in his arm. And when you look at the biopsy, you have these spindle cells with this little oval cells, and you get fraught by these multinucleate giant cells, which are actually reactive muscle fibers. And when you have this clinical scenario with these bland-looking spindle cells, one marker that helps you is beta-catenin, and the diagnosis of fibromatosis is in place, because now you don't have to excise these large tumors because they could be filling defects, and we have a lot of non-invasive ways in which fibromatosis are dealt with. At our center, we have the metronomic chemotherapy, then there is ablation, and the cryotherapy. These are the other non-invasive ways in which fibromatosis is dealt with. That's very important that we are able to pick this diagnosis and not say spindle cell tumor, I don't know, and the surgeon is in the quandary. So what are the indications of biopsy? Any soft tissue mass that is rapidly growing, more than 5 centimeters in size, painful, deep-seated, solid mass, and it's unresectable. And at all times, we always biopsy recurrent lesions, persistent lesions, or metastatic. So these are the important biopsy indications. And when you look at the parameters that we need to offer for diagnosis of sarcomas, we give grade, and that is the first time the pre-treated or the chemo-naive specimen on which we offer the tumor grade. We offer the TNM classification. If we made a diagnosis of sarcomas, we need to offer the status related to margins, and I'll come back into more detail. Histogenetic label, this cannot be substituted by grade or stage. These all are important individually, and we look at the ancillary techniques like IHC, which I actually don't feel now IHC is just a special stain that's a part of the diagnostic armamentarium. And what is more ancillary is maybe RT-PCR in FISH in select cases, and EM, because of its logistic reasons, has been taken a back seat in contrast when it was more popular. So looking at the grading of the sarcomas is a contribution from the French sarcoma experts and the parameters that we use. And that's the first question to my resident who gets posted in BSD. How do you grade a sarcoma? We use this system, and the parameters are tumor differentiation score, mitotic count, and necrosis. We score accordingly 1 to 3. And by differentiation score, I mean if your cell or the tumor cell type of the tumor, how it is resembling to the native the structure. For example, if you have a leiomyomatous tumor spindle cell, so you will assign a score of 1, in contrast to pleomorphic sarcoma, which is completely grade tumor differentiation score 3. Certain tumors, by their virtue of their type, are assigned differentiation score 3 and the final grade as well. For example, alveolar soft part sarcoma. You never have a low-grade rhabdomyosarcoma. Synovial sarcomas can be intermediate to high. Epithelioid sarcoma is invariably a high-grade sarcoma. Myxoid liposarcoma, at least grade 2. So that's how we have certain caveats that we need to know. And finally, we total all these parameters to offer, whether it's score 2 to 3, which falls into grade 1, 4 to 5 is grade 2, and 6 to 8 is grade. That's a very, very important parameter to offer to our clinical colleagues. And that stood the test of time, because you can see with increasing grades, there's a significant decrease in the 3-year and 5-year survival. It's been seen. That's the evidence, what comes very clearly. And also the staging, and wherein the staging, when I say important, is that we know whether it's a deep-seated tumor, it's more than 5 centimeters, because that escalates the grade, the stage. And And finally, if you have a nodal metastasis or a distant metastasis, that clearly defines a sarcoma as high-stage sarcoma. So it's important to know when you're handling a soft tissue tumor that you know the age of the patient. I can't overemphasize on this fact because you will not diagnose a liposarcoma in a pediatric patient, and you will rarely diagnose a lipoblastoma in an older patient. Of course, there can be very rare chances, but that's what one needs to have in mind. Duration and tumor size, for example, if you have a superficial tumor which is barely reaching the size of 3 centimeters, and it's freaking out the clinical colleague, and maybe you, when you see mitotic figures, it actually could be nodular fasciitis. So size and the growth pattern is very important. If there's a history of malignancy, because we, previously, and there's been a treatment, for example, radiation, we know the radiation-induced MPNSTs with those histone 3.3K26 M we are picking up these days, 27Me3. So that's what I would like to come towards the grossing part of it, and that was some time back when we used to have excisions like this, and what surgeon would wonder whether he's cleared it completely, he or she. And you can see this is just the tumor enucleation, and the tumor remains will be in the body. And we don't get to see these specimens now too often because this is an incomplete resection. And that brings me to important aspect of the margins when we say radical resection, which is generally not commonly done, but if there's a tumor which is infiltrating the compartment and going beyond the usual, then they plan a radical resection. We have the plane of excision beyond the tumor compartment entirely. What is most commonly tried to do, they try to do is a wide excision when you have the plane of resection going through the pseudocapsule. So soft tissue tumor weaves the pseudocapsule, goes kind of centrifugally, and the plane of resection has to be beyond the pseudocapsule to label that excision as wide. We have a 1 centimeter sized cutoff, but that might not be always possible for the surgeon if he's dealing with a large sized tumor, and then we call it as a qualitative margin. If there's a fascia that is removed, that's good enough. If your plane of resection is through the pseudocapsule, it's called a marginal resection, and an intracapsular resection is generally not, what they would go for, unless it is a hugely, tumor, or mostly for benign tumors, because you have the plane of resection touching the tumor. And then we call these as either R0, R1, or R2. R0 is grossly and microscopically free, wide, that is the ideal choice for sarcomas. R1 is grossly free, microscopically positive, marginal, and therein lies the offering, the choice or possibility of offering adjuvant radiation therapy for a better loco-regional clearance. And if it's a grossly and microscopically positive, that's what generally is not recommended for a sarcoma. It's called as intracapsular excision. So then if there is a tumor close to a nerve or a vessel, they need to do the engraftment, and that we need to be offering parameters related to the nerve and vessel cut margins as well. That's the real specimen. You can see how we do, just like, you bread loaf a breast specimen is how you do exactly a soft tissue tumor, orienting with short superior long lateral sutures. This is the outer, surface which is painted. You can see the tumor cut surface, which is in one section you can see here. Now, if you imagine that this is, a kind of a, So if you imagine that there's a pseudocapsule around this tumor in form of this yellow margin, and if your plane of resection is passing through the normal tissue which is here in the ink surface, this is what I was referring to, R0 wide excision. If it is going through the pseudocapsule, we call it a marginal excision. If it's passing through the tumor, that's called the R2 or intracapsular excision. That's what we generally avoid. And this is a case of a wide excision specimen. So this translates microscopically towards seeing as positive inked margins, calling it as maybe a marginal, or in this case it was an intracapsular R2 resection. When I speak about margins, if the tumor is close to the ink surface, we generally take a radial margin, just like we take in head and neck specimens. And if it's away, we take the shave margin. If there's a tumor in the shave margin, it clearly denotes that there is the tumor and it needs to be further resected. Then again, I was referring to the nerve and vessel cut margin, the radical resection specimens. So coming to the most important or fascinating aspect towards what we do in daily practices is about labeling sarcomas. It's all about pattern recognition, pattern analysis. And as Madam was just referring to, it's like in soft tissue tumors, it's almost like going to a textile. When you look at the different patterns and your thought process goes towards the appropriate choice of the IHCs or molecular accordingly. And what you need to analyze here is the various tumor cell arrangements, maybe the herringbone pattern, which we used to allude to fibrosarcoma, which is actually not, but you see more common in synovial sarcomas and MPNs and things like that. Then if you have a rosette-based round cell tumor, you know what thought process is going to be towards. The stroma, whether it's predominantly myxoid tumor or chondro-osteoid matrix, and you can have your further thought types, kind of giant cells, because you will see Teuton giant cells and more fibrohistiocytic tumors in contrast to wreath-like tumor cells, which you see in alveolar rhabdomyosarcoma and maybe in clear cell sarcoma of soft parts. Pleomorphic cells you will see mostly in pleomorphic sarcomas, but there are caveats, and I'll come to that in certain specific cases. Vascular patterns are very important in myxoid tumors, because if you have a curvilinear pattern of vessels, you see mostly in myxofibrosarcoma. If you have this chicken wire, you mostly attribute to a myxoid liposarcoma. And if you have this swirling pattern of blood vessels, you see more in a low-grade fibromyxoid sarcoma, that is the Dr. Evans tumor. And looking at the cell type, it's going to be towards cytology. And as cytology, I say it's not a separate part of histopathology. It's a 60x of histopathology. So it just beautifully integrates. And you can see whether your tumor is predominantly pleomorphic, spindle, round, adipocytic, or polygonal. And there can be an interplay. You can have your tumors which are pleomorphic to spindle cell and polygonal to round cell. And why it is important? Because you have certain chemotherapies lined up specifically for your round cell tumors, including the Ewing sarcomas, rhabdo, neuroblastomas, and lymphomas, in contrast to the other tumors which are generally dealt with the excisions with choice of adjuvant radiation therapy, except for certain specific chemosensitive tumors if they are spread and then they contemplate chemotherapy. For example, synovial sarcoma, leiomyosarcoma. These are more chemosensitive in contrast to pleomorphic sarcomas, which are chemoresistant. So we need to pick out these tumors clearly, correctly. What we can bank on further is towards the recent literature, that is the WHO Fascicle 5th edition 2020. I was fortunate to be a part of authoring some chapters, and a nice edition 6 of the Inzinger Wise by Dr. Falk. What we've done and happened in the soft tissue tumors fascicle recently also, it's not been changed in terms of the way we are classifying tumors, essentially on the lineage, and the same way trying to stratify every lineage-based tumor into benign, intermediate, malignant, or malignant. For example, you have a lipoma as a benign tumor, an atypical lipomatous tumor / well-differentiated liposarcoma as an intermediate malignant tumor, and the malignant counterparts are going to be pleomorphic liposarcoma, dedifferentiated myxoid, and now we have the pleomorphic myxoid liposarcoma as a new variant. So accordingly, you have also in the vascular, you have hemangiomas to hemangioendotheliomas to the angiosarcomas as the malignant counterpart. And what is new is a couple of entities, new markers, and molecular subtypes. In the adipocytic tumor, we have the spindle cell pleomorphic lipomatous tumor. It just almost looks like an ALT, but it lacks the MDM2 gene amplification. And in the malignant counterpart of lipomatous tumor, we have the pleomorphic myxoid liposarcoma, mostly in pediatric patients in locations like mediastinum. You have a superficial CD34 positive fibroblastic tumor that looks like a pleomorphic sarcoma, occurs mostly in superficial sites, consistently shows diffuse CD34 positivity. You have certain genetically defined entities like EWSR SMAD3 rearranged tumors, kind of rare emerging entities. In hemangiomas, you have different flavors related to synovial, intramuscular, and anastomosing hemangioma. Epithelial hemangiomas are coming in two genetic flavors now. You have the YAP1 TFE3 and the WWTR CAMTA1 positive epithelial hemangioendotheliomas. In the smooth muscle, you have the Epstein-Barr virus associated smooth muscle tumor and an inflammatory leiomyosarcoma, which is kind of being debated and discussed whether it's a histiocyte-rich rhabdomyoblastic tumor, or do we call this as inflammatory leiomyosarcoma, as Dr. Fletcher has designated it in the recent fascicle. You have the ectomesenchymomas as part of the skeletal muscle tumors. Conceptually, melanotic schwannomas are now the malignant melanotic nerve sheath tumors because they behave aggressively, is what the works of Dr. Falk and Dr. Meera Hamid, who've written the chapter on this in the WHO fascicle. A very important revolution has happened in the undifferentiated round cell sarcomas. We are designating these or trying to stratify these again into genetic flavors. You have the Ewing sarcoma that is now genetically defined as a tumor which is round cell morphology, it has a FET or TET gene, that is the EWSR, with a fusion partner, that is the ETS family of transcription factors. If you do not have an ETS family of transcription factors with a EWSR gene fusion, you call that as the other category, the EWSR non-ETS fusion, like the PATC1 or the NFAT-C2 positive tumors. You have the CIC or chick rearranged sarcomas, which completely don't show the EWSR gene rearrangement, and then you can have sarcomas with BCOR genetic alterations. A very theranostic importance of this entity is the NTRK positive tumors, mostly seen in pediatric patients, and these have the targets. If they are unresectable, large size, larotrectinib is the target for these NTRK rearranged tumors, which is also being seen in tumors like GIST now. And we have new markers like STAT6 for solitary fibrous tumor and FOSB for pseudomyogenic hemangioendotheliomas and also for osteoblastomas. So the value of histogenetic label, which cannot be substituted by grade, is in these scenarios. You have the GIST. We know the success story of GIST with imatinib and now sunitinib and the other IBs which have being offered to these patients who have resistant GIST. Pediatric round cell sarcomas, including lymphomas that I just alluded to. You have sarcomatoid variants of organ-based tumors because the sarcomas will be dealt with I4-ADRIA in contrast to platinum-based chemotherapy that is offered to sarcomatoid carcinomas, which might not respond. You have certain specific spindle cell sarcomas like synovial sarcomas, which are chemosensitive, in contrast to its close mimic, that is MPNSG, which is intermediately chemosensitive. Lipomatous tumors like myxoid liposarcomas are being dealt with drugs like tebectedine if they're spread out. And we know germ cell tumors melt with the BEAP regime in contrast to the carcinomas that they mimic. So it's important to stratify these. And how we do it? We integrate morphology with our good friend immunohistochemistry for a more precise diagnosis and fall back on the molecular techniques, including cytogenetics, interface cytogenetics, that is FISH, for a more accurate diagnosis. And coming to certain case scenarios, most common is this. In a young male, you have a mass in the patient had a mass in the popliteal fossa, and you see this very busy spindle cell tumor. It strikes you in lower magnification, these delicate thin-walled blood vessels branching. And when I see this, the first thing that I'd like to do here is CD34. And if you have it positive, it goes towards one side, and if it's negative, you know what you're dealing with. So that's what we know fondly as the staghorn pattern of vasculature, exemplified in this cartoon. And this was offered by Stuart Murray as the hemangiopericytoma. And over the years, we've seen that hemangiopericytoma is a very restricted and almost a bygone entity, because a lot of tumors that were designated as hemangiopericytoma actually are other tumors with an HPC pattern. And I think we all know about that. So these are 4 tumors that I came across with this very prominent HPC or the staghorn pattern, which were referred either with a diagnosis of hemangiopericytoma or with the differential of hemangiopericytoma. Let's see how immunohistochemistry helped us. In case number 1, it was a desminin myogene positive rhabdomyosarcoma spindle cell type. In case number 2, it was a BCL2 calponin MYC2 positive synovial sarcoma, standing positive with the SYT-SSX translocation on RT-PCR. If you see this very clue towards these cells indentating into these herniation of the tumor cells with this more polymorphic picture, I think more towards an MPNST with this tumor was this variable S100 protein expression, and lo and behold, the tumor that didn't show actually in HPC was CD34 diffusely positive hemangiopericytoma old school, now called as solitary fibrous tumor. So coming to our case, we had EMA positive in this, and it was CD34 negative BCL2. This was a monophasic synovial sarcoma that is the most common adult spindle cell sarcoma that we see at our center. And the landscape of synovial sarcoma over the years has completely, moved so much. Why? Because it's a chemosensitive sarcoma, one of the most common in young patients. And you can see variable keratins we used to throw in. Then TLE1 came in, which is still the essential marker in the WHO fascicle. You have the essential and the desirable features for all entities, and TLE1 is one of the markers, which is not very sensitive. It's very sensitive, but not very specific. And that's our experience about 42 cases of synovial sarcomas that we published in IJMR. And we looked at the sensitivity is high, 90% or more, but the specificity is lower because you can see other tumors like MPNSTs, schwannomas, which show consistently TLE1 positivity. I use INA1 in terms of its weak to absent expression to substantiate a diagnosis of synovial sarcomas. But what is new on the block is SS18 SSX antibody by an excellent paper by Jason Hornick, I think in AJSP, and it's a very highly sensitive and specific antibody for reinforcing a diagnosis of synovial sarcoma. So coming to the other tumor that shows this similar HPC pattern, and you see this patternless collagen throughout, And when I see this patchy CD34 positivity in a tumor like this, I go towards this marker that is STAT6. And when I say STAT6, I think that's it. It's one of the very few markers that has stood, in terms of its high sensitivity and specificity, and actually mirroring towards the underlying genetics that these tumors have, the 8 variants at the NAP2 STAT6 fusion that drives SFTs. And why SFT is an important tumor? It's a ubiquitous tumor across the body, and it's very easily misdiagnosed, underreported, or maybe wrongly reported, because CD34 is again a very non-specific marker, and rarely we've seen CD34 negative and STAT6 positive tumors. So you can see a diagnosed synovial sarcoma is towards a high-grade sarcoma, and solitary fibrous tumor, which is such a mimic to synovial sarcoma, actually could be a benign tumor. Of course, it has its own malignant counterparts as well. So this marker is mirrored towards the underlying genetics that I just mentioned, and that's good to work on. For a diagnosis of SFT. We published our series in pathology research practice. 33 SFTs, all STAT6 positive, 30 out of 33 were positive, for one of the 8 variants of the NAP2 STAT6 fusion. And this helped us to uncover SFTs at the conventional sites, that is thorax and abdomen, most commonly including pelvic locations, to rare sites like hand, prostate, and bladder. And we've also seen in pediatric patients reported. So the other sites that we've uncovered SFT is in the bone, where it was clinico-radiologically in osteosarcoma, and actually it was an SFT, so they didn't have to do a radical resection. They were just good enough with removing that tumor. Also in female genital tracts, you can have this SFT, where it can mimic a lot of other tumors. So it's important if you are able to pick this tumor in time. Coming to another scenario of a spinal cell tumor with a skin nodule. Now you have a scenario of maybe more than one lesion, and you see in lower magnification, this is very polymorphic picture in contrast to the previous one that I just showed was more monomorphic spindle cells. Again, you have the same HPC pattern, but you have this sprinkling of the lymphocytes, maybe a little myxoid change, and more pleomorphic cells, and that's clearly a malignant tumor. Now brings me to this pattern of the story-form arrangement that we've always, and it's nicely exemplified by this painting from Vincent van Gogh, a Dutch impressionist, and that's one tumor that shows the same pattern of this classically. And can the postgraduates tell me what this marker could be? Only for the postgraduates, which is a peculiar pinwheel arrangement, and this marker is just one to reinforce that diagnosis. Postgraduates, anybody? That's yes. So it's a CD34 just to reinforce your diagnosis of a DFSP, and what tumors show this story from growth pattern, apart from DFSP, which is the most representative, the pleomorphic sarcomas, we don't use the word MFH anymore, fibrocytic tumors, leiomyomatous tumors, MPNSTs, synovial sarcomas, and occasionally and SFTs can do that. And that's more often that we try to look at the honeycomb pattern of the fat infiltration in this otherwise spindle cell tumor, which is showing this pinwheel arrangement of the cells, and the marker is CD34 reinforcing diagnosis of DFSP. You don't need anything more than this. Of course, you have a genetic fusion that's called 1A PDGFR beta fusion. And coming to our case, another case showing this spindle cell tumor, frankly malignant, with this mitotic figure in the middle. You do a desmin in this otherwise tumor which is showing whorls, and it's also positive at caldesmon, that's a leiomyosarcoma. Coming to our case, more pleomorphic, which you see this giant cell jumping out in the lower magnification, and it was S100 protein positive, and that was an MPNST. And you know that there was a skin nodule as well, apart from this main tumor, and what was that? This was perhaps a neurofibroma, and this was S100 positive. So you can see this was a scenario of an MPNST in an NF scenario. And when I look at the markers, what you see in nerve sheath tumors, this is a good analogy towards this plexiform neurofibroma, because you see S100 highlights the Schwann cells, CD34 highlights the endoneurofibroblast. You can see neurofibromas showing CD34 positivity, and they have been misdiagnosed as DFSP. So you need to know a diffuse neurofibroma can be a mimic towards a DFSP. You make sure you're putting an S100 or now a SOC stent for that. And EMA highlights the perineural aspect of the tumor. So that's 3 stains I try and use for the nerve sheath tumors. And that's a very important nerve sheath tumor with this onion bulb arrangement of the cells, if you'll agree with me. EMA is highlighting the perineural aspects of this tumor, and S100 is highlighting the Schwann aspect of this tumor. And that's a hybrid Schwannoma perineurioma described by Jason Hornick in the 2013 fascicle, still in the recent fascicle. What you see with S100 protein in MPNs is mostly variable. It's again not a very specific stain. It's kind of 60 to 70% sensitive in our experience that we published in MP-NSTs, and that's not a very choice marker. Now we have better markers for MP-NST, and you can see rarely MP-NSTs with glandular differentiation. You can see this S100 reinforcing in this other Elizabeth Tomiko. So these are 0.2% of the GI tumors, more commonly 40 to 60%. 10% can be extra GI, that is the aegis, what we call them. The cell of origin is the interstitial cell of Cajal, and all GIS are considered to be with a possible malignant potential. And these are the markers that we use, but what is the gold standard? It's demonstration of the mutation. That is the c-KIT or PDGFR c-KIT in the vast majority of more than 80 to 90% cases. And apart from the 9-11 exons, you have the prognostic implications towards the various mutations. And now we have the SDH deficient GIST, more epithelioid in pediatric patients that we need to identify. So the differential diagnosis will be a smooth muscle tumor, a nerve sheath tumor, a solitary fibrous tumor, which will be CD34 positive. GISTs can be CD34, but they'll be c-KIT negative and STAT6 positive. Now you have for these large unresectable SFTs in abdomen, which were thought to be spindle cell tumor, I don't know, Tnpciapm is a drug that our oncologists are contemplating. So you have the guidelines towards management of these SFTs as well. The other differentials are lined up here. You have a dedifferentiated liposarcoma, which can be c-KIT positive, and it can also show focal STAT6 positivity. But what is the gold standard will be the demonstration of the MDM2 gene amplification or the MDM2 staining, diffuse staining pattern with the IF2 clone. And then you can have the epithelioid tumors, which will be S100 positive or SOX10 positive as well. So I just thought moving towards the round cell tumors to bring to you, I think, very aesthetically appropriate, and just fascinates me, the Maitri Mandir at Puducherry. And that's what I mean by saying round, which is so perfectly round as a part of it. You can see every disc is so perfectly round in shape. And that's what I'm going to bring towards the round cell tumors spectrum. When I say we look at the perfectly round cells, and these three examples show this peculiar rosetting pattern that we've always had in our mind towards certain tumor types. In this case, one was a MYC2 positive round cell tumor. It was diagnosed as Ewing sarcoma, but when it came for FISH to me, it was EWSR negative. That kind of rules out more than 90% of Ewing sarcoma. And you can see this membranous MYC2 expression that we always alluded towards, in Ewing sarcoma. But when I looked at, again, I said, is it a rosette or is it an alveolar pattern? You are looking at the other way of this tumor, and this was desmin and myogenin positive. This was a alveolar rhabdomyosarcoma. This was PAX3 FOXO1 positive. Completely different chemotherapy regimes to be offered. So this brings the non-specificity of MYC2 and the more specificity of the genetics that we need to tailor towards cases like this. Now coming towards Ewing sarcoma, you have a monomorphic round cell pattern. We used to call rosettes with PNET. We don't use the word PNET. It's Ewing sarcoma. The term Eskin rosa is also not considered for the chest wall based pediatric round cell sarcomas. What we still do is continue to MYC2, which is, I think, kind of 99 tumors probably are showing MYC2. But you look at the MYC2 membranous expression to reinforce. It's not an absolute marker. But what is good is come up is the NKX 2.2. That is, again, a useful, but again, not 100% specific, but highly sensitive and relatively more specific marker. And you need to throw in an LCA because MYC2 can be positive in lymphomas and melanomas as well. And again, we know lymphomas are completely differently managed than Ewing sarcomas, and lymphoblastic lymphomas can be MYC2 positive. Now, apart from its round cell morphology, Ewing's has a spectrum towards more epithelioid change that you can see in entities like adamantinoma like Ewing sarcoma, which has been described, a sclerotic pattern that you can see in differential is a DSRC, which is more nasty tumor. You can rarely see a vascular pattern. This particular case was referred to us with a diagnosis of angiosarcoma. You can see a very rich vascular pattern because all these tumors were molecularly confirmed, and rarely you will see spindle cells. We need to think more tangent towards perhaps a BCOR positive tumor. So what next you need to go is triage the cases of Ewing's coming at unusual locations, or Ewing's showing a little difference in the pattern towards molecular testing by EWSR. Again, not very specific because you will see EWSR in a whole range of tumors. You substantiate your morphology, clinico-radiological features with molecular, and then RT-PCR will be more specific, but it's less sensitive. So coming to case number 3, again of a round cell tumor, which showing this, but the unusual part here is the age. And this was diagnosed as Ewing sarcoma based on our favorite MYC2FLI1 diffusely membranous positive. But my oncosurgeon told me, can you review this case? This is a 52 years old male with a scapular tumor. And I said, well, there are some apoptotic figures, and when I see tumors like this, just forget about the rosetting pattern. We don't want to miss on a lymphoma, which this case actually turned out to be. It was an LCA CD20 diffusely positive rosette forming B cell lymphoma, completely different chemotherapy regime. Rituximab based chemotherapy is what this patient will go, in contrast to A. So Ewing's generally is a pediatric tumor. If you see in older patients, go for molecular testing and your critical reviews. So coming to the role of immunohistochemistry in these 5 to 6 flavors of round cell tumors, we know the MYC2 membranous, we continue to use this. Now we have NKX 2.2, the Spanish experts use caveolin. Rhabdomyosarcoma, myoglobinis passe, you can remove this from your lab and bank on more myod1 or myogene. These are more specific skeletal muscle markers. Neuroblastoma, synoptophysin, chromogranin, NSC, CD56, again not very specific, but to reinforce. DSRCT, you demonstrate polyphenotypic expression with epithelial markers, muscle markers, WT1. The clone is important, whether you have an amino or a carboxyl clone. And then NSC, what we found useful to substantiate, but not very specific. We have a whole range of markers for NHL, and small cell osteosarcomas can also be MYC2 positive. So how do we differentiate is what we go for molecular testing. Ideally, and you can throw in NKX 2.2 if we have this entity which is kind of esoteric than actually as a subtype of osteosarcoma. So like I mentioned, these all tumors have their specific chemotherapy regimes lined up, and these are the examples of all the chemotherapies that are offered to these round cell tumors. And look at the success story of tumors like this at unusual sites like this. So you have a vulvar tumor with this patient who had a simultaneously lung mets, MYC2 positive, EWS rearranged, Ewing sarcoma diagnosed, and post-induction chemotherapy, you can see the lesions from the primary and the lung gone. She had a survival benefit of 1 year. Coming to more epithelioid morphology of a tumor in a young adult. Superficial, I said, sarcomas generally are deep-seated, but there you have an epithelioid tumor which is more superficial. And CD34 is a good marker because again A1, A3 will come positive in any epithelioid tumor, and this marker can differentiate this tumor from a carcinoma, and that's an epithelioid sarcoma. Again, you can have CD34 positivity. In the other tumor that has more carcinoma-like appearance is an epithelioid hemangioendothelium. So always reinforce your morphology with the choice of markers that you go for, ERG or FLI1, to further reinforce EHE. And what is good to reinforce a diagnosis of epithelioid sarcoma is a loss of INI1 or SMART-B1 that differentiates it from carcinoma, but to an extent. Now we have an INI1 deficient carcinomas also, and there's a whole range of INI1 or SMART-B1 deficient tumors. And again, this interesting case of a epithelioid tumor in a pelvic mass reported as adenocarcinomas on smears is understandable. But again, if you don't throw in the marker, just smart oncologists will ask you to reinforce or perhaps consider diagnosis of a GIST, which was epithelioid in this case, and it was CD117 DOG1 positive. So coming to this myxoid tumors is a paraspinal mass. You see this chondromyxoid tumor. And when you see these myxoid tumors, it's good if you're seeing epithelial morphology to throw in a choice of epithelial markers like EMA and the S100 GFAP, because this helps in reinforcing diagnosis of a myoepithelial tumor, mixed or parachordoma. These are the same spectrum. If you see moderate ATP, you upscale this tumor as a myoepithelial carcinoma. Sharing with you our experience of myoepithelial tumors that we published in FOCOS, and you can see these tumors also show the EWSR gene rearrangement. The fusion partner is POU5F1.
Excuse me, sir.
Yes, sir.
I think the dean has come, and we have to start the inaugural function. If you still have slides, you can continue after the inaugural functions.
Okay, so we can take on the myxoid tumors later on and further on. It's okay with me.
Okay, thank you.
Yes, yes.
TVMC, Dr. Ravichandran sir, Vice Principal, TVMC, Dr. Shantaraman sir, Medical Superintendent, TVMC, Dr. Balasubramanian sir, HOD, Department of Pathology, TVMC, Dr. Swaminathan sir, President, Tnpciapm, Dr. Sandhya Sundaram ma'am, Secretary, Tnpciapm, Dr. Chandra Mauleshwari ma'am. To the dais. Tirunelveli Medical College has a rich heritage of 58 years to its crown. Our institute runs with 38 teaching departments and 29 postgraduate courses. Currently, it's ranked at number 48 under the National Institute's ranking framework, Ranking List 2021. Our campus is known for quality learning, clinical skilling, professionalism, ethics, good interpersonal and communication skills, a tradition we pride.
தமிழுக்கு அமுதென்று பேர் இன்பத் தமிழ் எங்கள் உயிருக்கு நேர் விழாவை சிறப்பிக்க நாம் தமிழ் தாயை வணங்கி தொடரலாம்.
Now we request everyone to stand for Tamil Thai Varthu.
நீராறும் கடலொடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் வதனமென திகழ்பரத கண்டமிது தெக்கனமும் அதிர் சிறந்த திராவிடன திருநாடும் தக்க சிறு பிறைநுதலும் தரித்தனலும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிளமை திறம் வியந்து செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
Thank you everyone. Please be seated. A lamp does not speak. It introduces itself through its light. Just as light removes darkness, knowledge removes ignorance. Lighting the lamp is in a way an invocation of the waves of knowledge that are activated on the stage. It also means keeping the waves of knowledge generated constantly active through the medium of flame. So let us invite the dignitaries on the dais to invoke the light of knowledge by lighting Kuthuvilakku. Thank you everyone. We humbly request our head of department, Dr. Swaminathan sir, to give the welcome address. Please sir.
Kale Vanakkam. Pathology is not a problem to be solved, but the soul's way of working on itself. It's my pleasure to welcome our beloved Dean sir to this conference, who has been a huge pillar of support for our department and for the conduct of this beautiful conference. Welcome you, sir. I like to welcome Dr. Balasubramanian, our medical superintendent, sir, who has been a continuous support to us for all the academic activities of this institute. Welcome you, sir. It's my bound duty to welcome the vice principal, the captain of pathology, my close associate, Dr. Shantaraman sir, with whom I started my career in this college, and he has motivated me to start such academic activities here. It's my bound duty to welcome Professor Chandya Sundara ma'am, Professor and Head of Pathology, Sri Ramachandra Institute, Porur, and the President of Tnpciapm, who first gave us permission for us to host this meeting here, and been a huge support to me for the organization of this entire conference. Thank you so much and welcome you, ma'am. And the best person to welcome and thank is Professor Chandramouleshwar Madam, the dynamic secretary of the Tamil Nadu and Pondicherry chapter of IAPM, and who is the HOD of the Central Lab Omandurar Hospital, who has been a huge pillar of support for me. And a special thing about this conference is I have my senior professors and teachers who are sitting in front of me, who taught me pathology, and a group of friends who did pathology with me, who have come to this conference, and my postgraduate students sitting in front in various academic positions, who is sitting in the front to honor me, and my dear postgraduate students. So it's a unique combination of teachers, contemporaries, my alumni, and my students sitting in this place. I welcome you all for this conference, which has been so unique. And an academic event is not complete without the delegates. And I'm happy that we have around 300 delegates for the first time here, and the whole entire hall is full. So I welcome you all and appreciate your sort of interest to come here in spite of the COVID pandemic alert. And I welcome all the chairpersons for the event and the sponsors who have sponsored various events of this conference. And the saral climate of Nellai is with a breezy wind and slight showers has created a perfect ambience to learn. So I welcome you all with folded hands. Welcome you all.
Thank you, sir. We request our HOD, Dr. Swaminathan, sir, to honor our Dean, sir. Please, sir. Thank you, sir. Now we kindly request our Dean, Professor Dr. Ravichandran, sir, to address the gathering. Please, sir.
Good morning to all. At the outset, I welcome the dignitaries who have come from the part of the country to this conference. I feel happy, and it's really a heart-throbbing event because the hall is full with the students, postgraduates, faculties, and all. Pathology will be the game changer in diagnosing the patient always, because a clinician like me always stops with the clinical diagnosis, beyond which the pathologist's role is immense and vital. We have seen so many cases of myelodysplastic syndrome slowly turning into the malignancy. We have seen we are fumbling to diagnose so many secondaries where the primary could not be diagnosed without the help of pathologist. So updating the knowledge is very much vital in pathology, and I could see a lot of equipments which have come here to help you in diagnosing the disease. So abreasting the knowledge is a must for postgraduates. So all postgraduates should study well and attend the conferences like this. I wish the function a great success. Thank you.
Thank you, sir, for taking out time for us from your busy schedule. We now request Dr. Arasi Rajesh ma'am, Professor of Pathology, Dharmapuri Medical College, to honor our Vice Principal, sir, Dr. Shantaraman, sir. Thank you, ma'am and sir. Now we welcome our Vice Principal, Professor Dr. Shantaraman, sir, to enlighten our audience. Please, sir.
The respective dignitaries on the dais and off the dais, and my dear postgraduate students. It's been our dream to have a chapter conference in Tirunelveli in the year 2020. And of course, because of COVID, we couldn't manage it. And 22, Dr. Swaminathan on the chair has achieved the organization, and it's very, heartwarming to understand that there have been more than 275 registrations to this conference. So as a pathologist who is on the downslide, I have just one word to say to my younger students. The world of pathology is rapidly changing. The days of gauze and microscopy and understanding the cells using the ordinary light is slowly fading off, and it requires additional diagnostic support in terms of a lot of molecular studies. So I would request my future pathologists to kindly widen their prospect of looking into the different diseases, understanding the disease biology far more deeper than the diagnostic part of it. Generally what happens is the pathogenesis part of it is taken on the ride, and we concentrate on morphology. But actually the time has come that we need to dwell deeper into the biology of a disease, because when it comes to understanding a disease through its molecular aspects, we need a deeper knowledge of that. With that, I will come to the better part of it is, I am standing here, this is probably one big opportunity I have to thank my teachers who are sitting in the front row. Dr. Vijayalakshmi ma'am, Dr. Sita Lakshmi ma'am, Dr. Ali ma'am, Shanti ma'am. I think they have taken me back to the days when I was a postgraduate like you, sitting in the back benches with these stalwarts occupying the podium and talking to us. And now I am waiting for my retirement. It's a huge change. And Professor Kalevani madam, who was my first mentor and my biggest mentor in my life. So I think, I don't know where she is around. And there is Professor Dr. Siddhi, who was my co-worker when I started off my career. Dr. Paramasivam sir, who was again a professor when I started off my career. So it is quite very emotional to see all of you here, and equally emotional is to see my own classmates who are professors and heads of departments in the various colleges. Dr. Aruna, I don't know where are you? Probably she is gone out. Yeah, Dr. Aruna, Dr. Padma, a whole lot of them. So I thank Dr. Swaminathan for giving me this opportunity, calling me into this conference. And also it's also very happy that some of my students, like Dr. Meenakshi Sundaram, and he has come here with a lot of grey hair. That makes me feel very old. So next time around, I request my students to come with a blackened hair. So I thank all of you thank Dr. Swami and his team for giving me this opportunity. I wish this conference a great scientific temper. And I thank on behalf of the organizers, I thank all the speakers and guests who have come here to enlighten us. Thank you so much.